Yay Media Group.
I would say that it is unpleasant to have a food allergy, but if you're going to have one, today is the best day to have one because you have options for treatments. We're in a place of let's get the diagnosis right, and then let's provide treatment options that are right for your family's season of life. And there's no better time than right now.
A quick note before we dive into today's podcast. If you like what you hear, I would love for you to subscribe to Fueled Wellness and Nutrition, wherever you download your podcast. It would also be incredible if you take a minute to rate and review this podcast. Those things do matter and they really help us. I'm Molly Kimball. Welcome to Fueled, a wellness and nutrition podcast. I'm a registered dietitian and nutrition journalist with a passion to help people live their strongest, healthiest life possible. In my weekly TV segments and columns, there's a limited amount of time and space to cover everything, but there's so much more to share. This podcast is my opportunity to dive deeper into the topics you want to know about. Food allergies can feel incredibly overwhelming, especially if you're navigating that risk of severe reaction in everyday life. But for some, it's possible that that goal doesn't have to be just pure avoidance. It's possible that some can look to reduce that risk and improve safety and feel like you're living more freely. So today we're talking with a leading allergist. We're joined by Dr. Hoyt. She is a board-certified pediatrician, internist, and allergist who specializes in the diagnosis, the management, and treatment of food allergies, especially in children. And when I first met Dr. Hoyt, I was just, I forget to mention too, she has a degree in nutrition. So she's bringing together just this wealth of information to really serve patients just optimally. And what I love too about Dr. Hoyt is she takes these really complex conversations, these really complex concepts, and really distills it down for patients to easily understand. And the more that we're understanding, the less fear there is, and the more that we're able to really take this guidance and apply it in our everyday life. We'll be talking through what's driving this rise in food allergies. If we know what's driving this rise in food allergies, how to recognize, how to respond to reactions, what to know about early introduction of certain and specific types of foods, and how treatment for food allergies is evolving in ways that are just changing the outlook across the board. So with that, welcome, Dr. Hoyt.
Thank you so much for having me, Molly. I'm super excited to be here to talk with you today.
So when I learned about you, I was like, wow, the credentials, board certified pediatrician, internist, also allergist. We didn't mention you also have a degree in nutrition.
Mm-hmm, that's right.
So bringing all of this to the table to support your patients is just since our paths have crossed, anybody who has anything that's food allergy related, I'm like, you've got to go meet with Dr. Hoyt. So tell us a little bit more about you and the path that got you here.
Absolutely. So when I was in college at LSU, I knew that I wanted to work with patients. And so I didn't major in biology in case I didn't get into medical school. And so I majored in nutrition, which made perfect sense to me. I spent a lot of time on my grandparents' farm in Ponchatoula growing up, where they grew all these foods and they were fresh. And so it made so much sense for me to major in nutrition pre-med at LSU, which is just such a gem of a program, and was very blessed, very fortunate to get into medical school. Initially thought I wanted to do a lot with public health, which I end up doing a lot with public health.
Every day, right?
Every day. But actually, after medical school, went into what's called med-peds, or internal medicine and pediatrics. So I learned how to take care of little babies, pregnant moms, and well into adulthood. And during that time, I was still feeling called to really niche down with the immune system and spent a lot of time with GI. And I was like, I'm just not. Colonoscopies are I'm so grateful people do them, but that wasn't where I was called. And one of my mentors recommended that I look into allergy, and I did, and started reading the journals. I was like, oh my gosh, this is exactly what I want to do. And that was when food allergy it was a thing. It was definitely a thing, but it's just a completely different ball game today, which we'll talk about. But that's how I got into allergy. And then just along the way, working with food allergy families in fellowship, extending my fellowship a year at the University of Virginia, Wahoo Wah, serving schools with helping them be prepared for medical emergencies like anaphylaxis. And then spent time at Vanderbilt on faculty. And that's really where I realized I love allergy, but I really love serving food allergy families. Moved up to Cleveland, worked at the amazing Cleveland Clinic, helped launch their food allergy center of excellence. And then when my husband was wooed back down here, he's a physician at Ochsner. We trained here. That's where we met, actually. Then I actually launched the Hoyt Institute of Food Allergy so that I could bring what I was doing at Cleveland Clinic and do it down here. We opened in 2021, and I just can't believe it's been almost 5 years. And I love it. I love focusing on food allergies.
So walk us through what the clinic is, how it's structured, what it's about. As you and I were talking, there was someone with us who said, Dr. Hoyt can cure the allergies, and you said, hold on, you were really quick to say, we're not curing, we're always,
right.
and so, but you're very, I don't know if the right word is aggressive, but you're very tailored and very specific. And it's not just about telling someone, yep, you've got this allergy, let's give you this medication and send you on your way. So tell us how the clinic is structured and kind of what sets it apart.
Right. So we have a very, what I call an engaged care model, where I spend a lot of time with my families. We cannot treat until we have a very clear diagnosis. And there's a lot of messiness when it comes to food allergy diagnosis because there's the testing, the evidence-based testing of looking for IgE to foods, that is often not interpreted correctly. Really, only a board-certified allergist knows how to properly interpret that test. Some very well-trained pediatricians, internists, family docs, and some of our advanced practice nurse practitioners, physician's assistants, they can be trained on how to do this, absolutely. But if you're wondering if your child has a food allergy, you definitely want to see a board-certified allergist and have the right test ordered. Because if the wrong test is ordered, then it's not going to give you the right information. So we really focus on getting the right diagnosis and then providing the most advanced treatment options. Avoidance of an allergen is still absolutely a management strategy for some families. Oral immunotherapy, where we're using small amounts, say if your child's allergic to peanut, we're going to use small amounts of peanut butter and over about 12 months, increase that amount until they're eating about half a teaspoon. Keep them on that for a year, 2 years, depending on their age, and really grow them into what's called freely eating the allergen, growing tolerance to the allergen. Also do sublingual immunotherapy, which is sort of microdosing small amounts of the allergen so that over a longer period of time, they're able to grow at least to bite safe, meaning if they were to accidentally eat something with peanut or egg, whatever their allergen is, then they won't have a severe allergic reaction. At the end of the day, we're always thinking, what is the best treatment for the patient in front of us?
You also asked do you work with adults? And while you do, you said most of your patient base is children. And you kind of noted that a lot of times if an adult has a food allergy, they think, I've got this covered, I'm good. I've had this for the better part of my adult life or maybe their entire life. And they think that they've got it under control. But when it comes to the children, parents are like, what do we need to do? And that's where the concern happens. I would think, though, that with adults, there's still so much you could do. That's kind of an untapped space there, too.
You're hitting the nail on the head. And what we're also thinking about in this space of that patient in front of us is if this is an adult, then their immune system is pretty set in, as opposed to a 1-year-old, a 2-year-old, where their immune system is still figuring itself out. And we can more easily convert that allergic immune system in a baby, in a toddler, into not allergic to the food than we can in adults. That being said, we can still do it in adults. But you're exactly right. So many times adults are just kind of like, look, I've been dealing with this all my life. I'm fine with it. But if they have a child who has a food allergy, they don't want that for their child. And if there is something they can do to help leave the allergy in the rearview mirror, which if we start therapies early enough, many times we can, then they want to do that. Now, you also said something about cure. You're exactly right. We never say that this is going to cure anything. And if you're hearing, listener, if you're hearing out there someone saying they can cure something, take a step back. What a cure is when you have a condition, you apply the treatment and the condition goes away, and then you can remove the treatment and the condition doesn't come back. But when it comes to food allergies, our goal is to get the food in the diet safely so that the person can live a life not having to strictly avoid the food, not having to avoid the food at all.
I would imagine there's such an element of reward in daily in your clinic because there's so much fears that are surrounding food allergies. There's, you know, there's only so much that someone can feel comfortable with looking at labels and feeling like they have to be in control of every single element that is going into their child's space. So
Mm-hmm.
this is life-changing for people to be able to have, at least even somewhat of a tolerance. Like you said, if they can have one bite and things may not be life-threatening, that alone can be life-changing. I would imagine there's a lot of tears and gratitude at times, like good tears and gratitude in your office.
Mm-hmm. Yeah, I was just pulling up a note that one of my patients sent me last week. This is a little guy in preschool aged, and he's gone through peanut immunotherapy with peanut butter. And his mom was filling out a fan fax about me. And it says, I am allergic to peanuts, but thanks to Dr. Hoyt and oral immunotherapy, I can now eat as much peanut butter as I want with my parents. And I literally just started kind of tearing up because you're exactly right. This is why I do it. I love getting pictures from my
Yeah.
patients of their child just chowing down on their allergen.
Yeah.
And I mean, this is a little guy who sent the note. This is a little guy who, we did the challenge in the office, and such a small amount of peanut butter caused quite the reaction. So to see them go through it, it's a process. It's not overnight. It's a couple of years, depending on the age, to get them to freely eating. But to walk with them along this journey and to be their guide along this journey, they're the ones putting in the hard work. They're the ones giving the dose every day, making sure the kiddo is not running around doing lots of sports or getting really, really increased body temp, increased heart rate. So there is some planning to this as to when you do the everyday dosing at home. Doing the up doses. Initially, this family is from a couple hours away. They would drive in, stay for an hour, hour and a half while we do the up dose. They do the doses then every day. We were able, because he was doing so well, to convert to virtual up dosing. So that saved their family a lot of
Right.
time scheduling. But to have that kind of that kind of outcomes and to have those outcomes regularly, it's not everybody, right? Nothing is 100%. But to have those outcomes many times, it is so rewarding, and it really fuels continuing to do this and share it and teach others how to do it, which I'm also very passionate about doing.
You do a lot of teaching, you do a lot of education, and I have so many questions that are popping in right now. One that we'll come back to is about are food allergies increasing? Are these on the rise? Whenever you said that, as you were kind of starting to think like, what is my specialty? And you started looking more into food allergies and you referenced, that was back then. Now there's even way more about it. How many years ago was it that you really started to immerse yourself in the study of food
So
allergies?
it was a little over 10 years ago, and I was doing residency 2010 to 2014. And so that's when I knew I was picking my fellowship. And that's when I was really very interested in food allergy. But so much has changed just
Yeah.
since then. It's
I've,
unreal.
the early 2000s up until it seems as if before, when would it have been that it just really exploded? Because I think about as a kid, there was very few
Uh
kids in
huh.
our class. There wasn't any in our class, very few in our school, if any, that
Hmm.
that was an issue. And now it's so much more prevalent. When when was that explosion? Was it like in the early 2000s? Was it the late 90s? Like when was that big transition?
So, such a good question, right? And I say, biblical Job, had a lot of stuff. He didn't have food allergies. If they were around back then, he would have had food allergies. His kids would have had food allergies, no food allergies. The uptick in allergies and really just noticing allergies like hay fever, allergic rhinitis. That wasn't until the late 1800s. And Dr. Thomas Platts Mills, one of my mentors from University of Virginia, he has a beautiful article in Journal of Allergy, Clinical Immunology and Practice. I'm pretty sure it's open access, so anybody can find it. But it's called The Allergy Epidemics. And he said that he was asked to write an article called The Allergy Epidemic. And he said, no, it's going to be the allergy epidemics because it's multiple conditions. Allergic rhinitis or hay fever is different from pediatric allergic asthma, is different from food allergies, is different from alpha-gal or the mammalian meat allergy that we don't really have around here. They have plenty of it in Virginia. But really, in the 1990s, the uptick in peanut allergy was noted. Because of that we don't know why, but in response to that uptick, expert opinion was, well, let's have kids avoid common allergens until their immune system is ready for it. And that was a recommendation in 2000. So no cow's milk until age 1, no eggs until age 2, no peanut, tree nut, shellfish until age 3. And then we saw a real explosion of multiple food allergies, not just peanut. So then those recommendations were kind of quietly walked back in 2008, but there wasn't good data on like, okay, well, what should we recommend to parents to prevent food allergies, right? Like
And they
it
were
was still
quietly walked back, like you said. A lot of people were still completely avoiding them.
right.
Yeah.
And I'll tell you, what you do as a pediatrician in training in your residency, that sticks. And when you come out of your training, it's hard to keep up, right, with best practice, but it's also it's hard to believe
Yeah.
when something new comes up because you've been doing something a certain way based on X amount of data, based on, your mentors who've had lots of clinical experience. So it's hard to make that change. But in 2008, it was quietly walked back. In 2014, 15, that's when the LEAP study came out, learning early about peanut. And that really demonstrated, 2015, that in kids, babies, who were at risk of peanut allergy, meaning they had severe eczema or egg allergy, they already knew from previous studies that those two things are risk factors for a peanut allergy. If they started feeding those babies peanut before they turned 1, so between 4 and 11 months of age, they started feeding them peanut regularly. Then by the time they were 5, they were significantly less likely than their counterparts who were strictly avoiding peanut. So we knew then, okay, early introduction matters. How that whole concept came about, very interesting, is Gideon Lack, who was the primary investigator of the LEAP study. He recognized that in Israel, they still had food allergies, but they didn't have peanut allergies. And he saw that little babies, one of their first foods was this little puff called bamba, which is like a peanut puff, but kind of like a Cheeto, but a peanut
Yeah.
Cheeto sort of. And so they were gnawing on that from the time they were putting anything other than breast milk formula in their mouths. And so he saw that and he's like, well, this has got to be helping. And he was right. And so since then, in 2017, the National Institute of Allergy and Infectious Disease made recommendations of, okay, we need to get peanut in early if they have severe eczema or if they have an egg allergy, they're at high risk. And it got a little bit complicated for a few years there because people didn't really know what to do with this information. They knew it was for peanut, but what about other allergies? And so now where we've come with other studies, other clinical experience is we need to get back to feeding babies the way babies have been fed for thousands of years, which is when babies are interested in foods, we need to start giving them real foods. And if there's a risk for them having a food allergy, which this is all new, right? We haven't had allergies for thousands of years. But if there's a risk, if they have eczema, if we already know they have another food allergy, we need to get the common allergens, peanut, tree nut, egg, milk, wheat, soy, sesame, and then fish and shellfish. We need to start getting those into their diet sooner rather than later and regularly, so early and often. And that can help prevent the development of food allergies.
So what is behind the explosion of it? Because there is the avoidance that seemed to have contributed to it,
Worsened.
but it's not, that wasn't the cause. So
Hmm.
what is the theory? Is
That is
there,
such a good question. That is such a good question. Um, we don't know. Isn't that a very un-
I
isn't
feel
that
like there's
so
like a
disappointing?
conspiracy theory
That's
under
so
here, you know?
disappointing. So disappointing. No, we don't know what caused that initial uptick. Like we have
Right,
so much more exposure to so many foods. Um, but what is actually causing it? There is thought of what's called the hygiene hypothesis, which is, as I'm sure you know, that as we've gotten more hygienic, our bodies are no longer fighting infections as regularly because we're hand washing, we're wearing shoes, we're drinking clean water. And Dr. Platzmills talks about those things in his article and how they align with the onset of allergies. And it's really fascinating to stop and think, like, why now? Why all of a sudden are our bodies attacking peanuts or pollens or penicillins? Like, why? And we don't know. Everything gets blamed. Often moms blame themselves, which I immediately tell them this is not your fault because, we look at our studies are looking at things like vaginal births versus C-section. Like, did you have antibiotics in that delivery time period? Did the baby have antibiotics? All of those types of things. And then what about food processing? What about vaccines? What about all these things that they're all they're all relatively new, right?
right.
Relatively
And they all kind
new.
of came in around the same decade or two, a lot of
This
them.
is this has been the time in which we're living is so advanced when it comes to medical care and treatment options and prevention, right? I mean, and I didn't even mention antibiotics or vaccines when I was talking about hygiene hypothesis, but
Right.
the most common cause of death used to be infection, right? Now it's not because we have antibiotics, we have hygiene. And so it's great. It's great. These are all very, very good things. But at the same time, our immune systems are no longer combating things. So is our immune system just getting bored and attacking things it shouldn't? I don't know. Now, would I go back to a time where we didn't have antibiotics, didn't have
Right.
vaccines? No, I would
Right.
not at all in any way, shape, or form. But these are things that need to be studied and the
Yeah.
questions have to be asked.
And the not knowing is probably frustrating,
Mhm.
to not have that full
Yeah.
understanding, but it also leaves things ripe for misinformation and fears and, like you said,
Mhm.
unnecessary, maybe self-blame along the way. So as has shifted, there's a lot of confusion also about food allergies, food intolerances, and food sensitivities. So,
Mhm.
there's many, many times, someone will say, I'm allergic to. And then once we start prompting and kind of prodding with more questions, we realize it's not a true allergy, but it's sort of the phrasing that people are most familiar with. So break it down for us for someone to kind of
Mhm.
understand the differences and also what to ask for if they're not sure. And I would say everything that we're saying I think a lot of what we're saying from this point forward will apply for adults too, who maybe
Mhm.
haven't really uncovered a lot of this conversation.
Right. So there are three core questions that I, as an allergist, use to help tease that out of what's going on in this child or in this adult. The first question I'm asking when I'm doing my history talking to a patient is I'm trying to tease out whether or not the symptoms they're having, if they only happen after they eat this food. Or do they happen other times independent of the food? Because if it's happening independent of the food, then it's not an allergy. Could it be an adverse reaction to the food? Like I get really jittery when I drink coffee, but sometimes when I drink other caffeinated drink, I get, things like that. So I'm trying to tease out, or the classic, especially with kiddos, is that they've been having hives for weeks and they've tried avoiding all these foods. Well, if they're having hives for weeks, then that is not a food allergy. So I know, okay, question number one, not a food allergy. We're going to explore why could this child be having hives, which, side note, the most common cause of hives in kiddos is a post-viral, pre-viral syndrome. The immune system is just a little more on edge, and in some kids, it responds by hiving. Can be very frustrating. Um, the next question I'm asking, if I'm thinking, okay, yes, this does seem like it's an adverse reaction to food, right? So the first question I'm teasing out, not an adverse reaction to a food. Next question, okay, it is an adverse reaction to a food. Does this seem like the immune system is involved, or does this seem like something else is going on, like some sort of an intolerance? So caffeine making you jittery, that's not an immune response, but that's definitely an adverse effect to a food. Lactose intolerance, not having enough lactase enzyme to break down the milk sugar. And then the person, as a result, ends up having bloating, diarrhea, can be incredibly uncomfortable. Similar things with gluten sensitivity, which some people don't believe in. I do believe in it. I think actually sometimes gluten sensitivity, egg sensitivities mean you kind of get an upset stomach, but then maybe it kind of goes away. Maybe you get some brain fog. I think some of this is actually underdiagnosed eosinophilic esophagitis, which is it can be a food allergy. I'll get to that in a minute. But really teasing out, is this adverse reaction to a food? Is the immune system leading the way here? Or is this something else going on? So then when we're thinking, okay, the patient comes in and it says after their child had scrambled eggs, then within a few minutes got red, had puffy eyes, vomited, then I'm thinking this is sounding absolutely like the immune system is attacking that food, is not liking that that food was ingested. Sounds to me like the allergy cells are being activated, specifically mast cells, MAST mast cells. These are cells that live in the skin, mucous membranes, and the gut, and they contain all of the chemicals that cause anaphylaxis. So they contain everything that causes hives, swelling, trouble breathing, drop in blood pressure, can cause bronchoconstriction, meaning tightening in the airways, can cause that wheezing, vasodilation, opening up of the blood vessels, which is going to cause the drop in blood pressure. And ultimately, if our blood pressure drops too much, our brain is not being perfused. And so this is how people can die of anaphylaxis. And so I'm hearing what the symptoms are after ingestion of the food to decide, okay, this is an adverse reaction to a food. This does sound like an immune-mediated adverse reaction to the food based on what's called the constellation of symptoms, which all those symptoms together right after ingestion, right? And then I'm deciding based on those symptoms, what type of adverse reaction, immune-mediated adverse reaction, which a food allergy is an immune-mediated adverse reaction. IgE-mediated, meaning that IgE, allergic antibodies, on those mast cells, they are what permit anaphylaxis to happen. If you have peanut IgE, that type of allergic antibody, hanging out on your mast cells, and you eat peanuts, then it's highly possible that that peanut's going to bind to that peanut-specific IgE on that mast cell and activate it. It's just like a lock and key mechanism. You basically have a peanut lock on your mast cells, and peanut unlocks it and activates your cells.
It's such a good visual. Yeah.
So
Thank you.
I'm a very visual person.
Yeah.
And so that is what I'm going through to try to decide, is this person having an adverse reaction to a food? If yes, what type is it? Because we cannot provide a good treatment plan until we are very clear on the diagnosis and very clear on what foods are safe and what foods are not safe.
Right. If someone comes in and they're having these issues and you identify, okay, this is a food, but it's more of a sensitivity or an intolerance, not a full-blown allergy, is that something you'll still help them with, or do you
Mm-hmm.
refer them out? Okay. So if
No,
someone has that
absolutely.
sensitivity, and I agree with you on the gluten sensitivity and others. I think, decades ago, as people first would say, I'm sensitive to gluten. I think there was a lot more eye rolls back then than there are now. And it was sad for them, and they felt dismissed by their providers. They felt dismissed by their peers, that they were just like, this was all in their heads. And so I do think while there are some things that we can work our own selves up about, there's so much that when patients are coming in and over and over, we're seeing and hearing the same types of feedback from patients, even if it's not fully something that we're knowledgeable about yet, there might be something to it. And so
Mhm.
not being so quick to dismiss just because we don't have the answers yet, but to start to pay attention to
Right.
what's rumbling around and coming in. So yeah, I fully agree.
1,000,000%. And that is how we have lost a lot of trust in communities with
Right.
patients, is by poo-pooing people when they have legitimate symptoms, and we just poo-poo them because we can't go to our textbook and find what they have.
And then where do they go for
The
support?
interwebs, the
Right.
interwebs,
Right.
and spend too much money on
Right.
tests that are not gonna help them and are just gonna muddy up the waters.
Where do we want
Yes.
to go next? What's our next on certain types of treatments that you want to talk about, like treatments in practice or prevention? Like, what are some of the next spaces that make sense that would are our next logical part of our conversation?
Yeah, I think prevention we've covered pretty well early and
Hmm.
often and baby appropriate. I had a family in last week, and I was very happy that they had started introducing some foods. We're still kind of hesitant on some, but for the most part, mom and dad were avoiding the baby food aisle. And that's somewhere that marketing is just so strong. But our babies, they don't actually need baby food. They need food that is safe and developmentally appropriate for them. And really, it's a test of what are we feeding ourselves? What's at our own kitchen table, for whether or not it's something baby can have. Really, babies can have, as you're the dietitian, right? But babies can have pretty much anything that we are eating. So if we're eating steak and the baby's ready for food, so has head control, is interested in food, all of these things, we're not going to give them just a piece of steak, but could we grind it up for them? Could we baby bird it? One of my favorite ways to feed young babies introducing foods is chew it up to a consistency that is appropriate for them. You know what it's doing? It is starting to digest it. It is the mastication, the chewing process is making it more appropriate for them who don't have teeth, right? Or maybe they're starting to have a few. So cute. And also the salivary enzymes are helping to break it down more, and it's being coated with IgA. And so it's just a gentler way. I know you have to baby bird everything, but like I want families to stop feeling like some sort of shame for baby birding. Baby birding, I mean, how did we feed babies hundreds of years ago, right? There were no food processors. There was no Gerber. And so it was what we're eating and giving it to them. Now, we don't want to do raw foods. We don't want to do anything with alcohol, of course, things like that. Anything that's too spicy, but really, the more we can start sharing our meals with our children from the time they're young, seeing that everybody's eating the same food and we're all sitting down together as much as we possibly can in this busy, crazy world, sitting down together and sharing time with each other and sharing the same meal with each other. And that was one thing that the family really was looking forward to, was being able to just share meals, because the mom herself was nursing and she was avoiding some foods, concerned about causing the baby to have a reaction. So, prevention, and not falling into the marketing ploys of, oh, your baby needs this extra nutrition from this baby food and you can only get it from this baby food. No, talk to your pediatrician about that. When it comes to treatments
I'm
for,
going to
and
chime in on a couple
yeah,
of benefits
yeah,
that I like that you pointed out, and I kind of want to reiterate. One, well, the cost to not put the money into purchasing separate and specific baby foods from the baby food aisle. So there's the cost that you wouldn't have there because it's going to be small amounts of what you're already putting onto your own plate at home. I really like to that connection or that awareness that if someone is going to be feeding their infant from what is on their own plate, there's going to be probably a greater mindfulness of what's going to be on their own plate.
yes, I can
That's the
attest
wish, I would hope.
firsthand to that.
Are you
Firsthand
seeing
to
this?
that.
Good.
Yes,
Good.
and myself.
Yeah.
When I had my first child, I was like, wow. I knew I didn't want to buy a lot of packaged things because I just I knew from my training, from life, like, no, she needs to eat. She needs to learn to eat what we're eating. And I was like, wow, well, what am I eating?
Right, right. Okay, I'll just give her some of what we're having. Well, wait, what is that? I've
Mhm.
seen, friends who are having babies, and as we're recording this, I have one that I'm going to a shower this weekend coming up. And as I'm looking at the registry and seeing what I want to get, I'm seeing so many options for things that are like a Ninja, a NutriBullet type thing to make their own baby food, and I love that. Is it more time? Yes, but do you have any tips for that you give parents that if they are making something like that and how they can kind of do it ahead and like be a little bit of a time saver?
Yeah, one of my favorite ways to introduce peanuts and tree nuts and cow's milk is to actually make little popsicles. And so they're also really nice for teething. But I like the one, I have no sponsorship or endorsement deals from Haka, but they have a really great silicone popsicle mold. And so that way you can make a mixture of like breast milk and peanut butter, freeze it. Always use creamy, smooth peanut butters, nut butters. Don't have any nuts in it. Um, but freeze it, and then the baby, when baby is at that age, the baby can just like chow down in the high chair with it. You don't have to worry because it's got that silicone cover. It's got little perforations in it. You don't have to worry about like a big chunk coming out or anything like that. So that's one of my favorite ways to get some allergens introduced early, and it's a really fun way for babies too.
And it's small doses. It's
Mhm.
small and slow that they're going to be consuming it. So, what are some of
Which they don't
the
have to do small doses of allergens. You can just
okay,
mix up a teaspoon of peanut butter with breast milk and just let them go for it.
right,
The likelihood that a baby's gonna have allergic reaction is pretty low, maybe 1-2% depending on the child. And if a baby were to have an allergic reaction, they're usually limited to skin reactions. Now, as babies get older, there's an increased risk of having a reaction. And that's why it is so important that starting even as early as 4 months, sometimes earlier than that, that we're thinking about and we're counseling our patients on, okay, when your baby starts having interest in food, then we want to open up that world to them. Now, if they do have risk factors for food allergy, then we're going to strategize ways to be very intentional about getting allergen into their diet sooner rather than later. Because as I can personally attest to, some babies aren't ready to really eat foods until they're 12, 13 months old, whereas some babies are looking at you at 3 months wanting your
right,
cheeseburger. So that's where it comes back to really having
right.
personalized recommendations based on the family's culture, based on that specific baby's risks of having a food allergy, and just having engaged discussions about it.
What are some of the challenges that families are facing?
I think really the biggest thing is to have good sources of information. And for the most part, that could come from a board certified allergist who has a good passion for food allergy. Online, there are absolutely good sources online. I have a podcast, Food Allergy in Your Kiddo, at Hoyt Food Allergy on the Instagram, where you can get blips of the podcast on YouTube and such. And then other groups like Solid Starts, they're great for how to introduce foods to babies, but really recognizing, okay, how do I even know what's a good resource? A good resource is one that has some credentials to it and is not fear mongering, is not trying to sell you something, is really focused on just providing you with good information. And so when you find things, I think families today are just totally inundated with information, some of it good, some of it not so good.
Right.
But you need to have a go-to to say, "Hey, I saw this online. Is this something I need to worry about with my child?"
I was going to ask you to share your podcast, and we'll link to your podcast. And you also have a newsletter. But if you can give another plug on this, because I think these are such great resources and free resources for people.
Yeah, thanks. So foodallergyinyourkiddo.com. The podcast is Food Allergy in Your Kiddo. You can also find it at Hoyt Food Allergy on YouTube. We do video now. And then also the newsletter. I have a newsletter called Joyful Living that is specifically for parents of kids with food allergies. Also, side to that, I have the Food Allergy Peds Hub, which is an online learning hub specifically for pediatricians, pediatric physician's assistants, nurse practitioners, where they can go and learn more about food allergies.
When we're looking at advances in treatment, advances in research, what's on the horizon that you're excited about that's coming, whether it's just getting here or for us to kind of keep our eyes out for the future?
So, oral immunotherapy is one way that we can take anaphylactic food allergies and make people significantly more tolerant to the food, meaning make them bite safe. If they were to accidentally take a bite of their allergen, they wouldn't have a severe life threatening reaction. This can be completely life changing to families, or even in some cases, get them freely eating the allergen. Some people say putting them into remission from the allergy, really growing tolerance to the food where they're eating it all the time and they're not having any adverse reaction. We see this much more commonly in our younger kiddos and babies, toddlers, because their immune system is still so malleable. We can really reprogram it and sustain that reprogramming, especially with continued exposure, which is what we want, right? We want to get the food in the diet and we want them to live their normal life, not avoiding the food. We can still do that to an extent in adults as well. It's just harder because their immune system is set in. So another strategy to help grow some tolerance to the food would be sublingual immunotherapy, which is using even smaller amounts of the allergen to typically get to what we call bite safe, meaning if someone were to accidentally have a bite of the food, they wouldn't have a severe allergic reaction. And why a family might choose SLIT over OIT is because when you're doing OIT, then you're dosing every day. And 1 hour before your dose of a little bit of peanut butter, a little bit of egg white, whatever it is, and 2 hours after, you need to be relatively calm. No increased heart rate, no increased body temp, because those things can lower your threshold to have an allergic reaction. So that can impact a family significantly. You can imagine if kids, especially our elementary and older kids, they have after school activities, all these things. Like, when are they going to dose their OIT and be observed by their parents? So now we have more data coming out that SLIT, sublingual immunotherapy, small microgram to a few milligram amounts of the allergen can induce bite safe tolerance, meaning a kiddo who maybe couldn't even eat half a peanut can now eat a couple of peanuts and not have an allergic reaction, which is amazing if you're the parent or you're the kiddo who is legitimately concerned they're going to have an accidental ingestion. They don't go to the ice cream shop with their friends. They don't, all of these different things that we do. Our life just focuses around food. Many times those things or activities are avoided because of concern of having an accidental ingestion. And I'll pause here because if someone has an accidental ingestion and a reaction, meaning they start having hives, swelling, trouble breathing, vomiting, the treatment for anaphylaxis is epinephrine. Epinephrine from an autoinjector, from the nasal device, it is just like epinephrine that's coming from your own adrenal glands to stop that reaction. Epinephrine counteracts all of those symptoms, counteracts the bronchoconstriction, so opens up your airways, counteracts the vasodilation, so tightens up the blood vessels so that you're not having that drop in blood pressure. But what epinephrine also does that antihistamines don't do, epinephrine is what we call a mast cell stabilizer. I talked about mast cells earlier. They're the cells that are being activated to cause the allergic reaction. Epinephrine is actually telling those mast cells, hey, chill out, stop reacting. And so in my practice, if a kiddo, we know he has a food allergy, say he has an accidental ingestion and starts having hives, I say go ahead and use your epi because we don't want to wait until you're having trouble breathing. We don't want to wait until you're vomiting. We know you've had an accidental ingestion. We know you're allergic. And we know you're starting to react. Use that epi to shut down the reaction. And we know that epi, when administered promptly, is what puts us at increased likelihood of a good outcome, as opposed to waiting. That whole concept of, well, let's watch and wait, or let's
Right.
give Benadryl and wait and see if they get better. That's not evidence-based. So you're giving epi from an auto-injector or the nasal. It's very safe. It's pre-dosed. There's only one way to really give it. Where we as healthcare providers run into problems is when we're trying to draw up epi in a syringe, make sure we have the right amount, the right concentration of epi, give it IV. In my office, I just stock auto injectors because I don't want to even think about that when we're
Right.
having any sort of reaction.
Right. And
So I wanted to
it's,
pause there and talk about that for a minute.
I'm glad you did, because we hadn't brought it up. What are the things that you would say give a parent or a family hope, and or things that you just want to make sure that they understand and their takeaway from this? Especially, I think, probably people who are newly diagnosed. But what are some
Mhm.
of the words of wisdom, if you would?
So I would say that it is unpleasant to have a food allergy, but if you're going to have one, today is the best day to have one because you have options for treatments, OIT, sublingual immunotherapy. There are biologics, one available right now that helps prevent allergic reactions when you have an accidental ingestion. It's called omalizumab or Xolair. Um, there's a peanut patch coming out. There are more and more therapies to help manage food allergy beyond, oh, well, here's your epi and come back and see me in a year or 5 years. We're not in that in that anymore. We're in a place of let's get the diagnosis right, and then let's provide treatment options that are right for your family's season of life. And there's no better time than right now for that. Like I said, it's still unpleasant to have a food allergy. My husband has a peanut allergy. It's unpleasant, right? It still gives me concern, but I know that he knows how to manage it. I know that he carries his auto injector. And so we have options, right? And we don't have to live in fear. We can respect the allergen, and with good evidence-based information applied to each individual child and that education, there can be respect for the allergen, not fear of the allergen. And that's really my goal whenever I'm seeing a patient. Take them out of the fear, ignore that sensationalized fear mongering that you're probably having fed you on the algorithm on social, and lean into evidence based information, good education to help make the right decision for you and your family.
I can't imagine anybody more perfect for the role that you're in than you. It's
Thanks.
just so perfect. I would imagine too, with the technology, with medical advances, there's got to be so much excitement for you professionally, because it's something
Mhm.
that, you know, it's in your family, it's personal, it's also just what you do. And things that may have seemed hopeless or seemed like this was just something that people have to accept, now there's potential for improvement, and then what you're seeing on the horizon is even more. And
Mhm.
actually, as this podcast drops, it will be Food Allergy Awareness Week,
Mhm.
and
Right,
so
absolutely.
we're recording a little bit in advance of that. But if there's any other things relevant to that week that are coming up, we'll include those in our show notes as well. Any last things
Awesome.
before we
No, thank
separate?
you so
Yeah.
much for having me. I have loved our conversation.
It's you're such a wealth of information, a wealth of guidance, also compassion and compassionate care through all of this. So there's 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 a lot of confusion, a lot of misinformation, and I think anything that we can do to help clarify and simplify for patients, for parents, for kids, adults, all living with food allergies. I really appreciate it.
Thank you.
A tremendous thank you to Dr. Hoyt for sharing her time, sharing her expertise. I can see why she has a podcast. I can see why and how her newsletter and her blog posts are just so useful. One of the things we didn't even mention, she has a lot of resources, continuing education courses, things even for restaurants to be more allergy aware with their staff. So just a true wealth of resources. I'll include the links that she and I talked about in the show notes of this episode, and let me know what you think. If there's things that you've heard here and you're like, wow, I didn't realize, I could make these changes, or that these approaches or these treatments were available. Or if there's things that you think, hey, I wish you would have talked more about this, we can always bring Dr. Hoyt back in. So anything that you get from this, or anything else that you want to learn about this, always, I want to hear about it. I'm registered dietitian Molly Kimball, and you've been listening to Fueled Wellness and Nutrition, the podcast. If you'd like more Fueled Wellness and Nutrition, please head over to mollykimball.com, and you can follow me, Molly Kimball RD, on Instagram, Facebook, and Twitter. And if you haven't yet, please go to Apple Podcasts and subscribe, rate, and review this podcast. Join us next time for another dose of Fueled Wellness and Nutrition. Thanks for listening, and stay focused on living your strongest, healthiest life.